All right. Hi, I'm Lindsay. I'm just putting together a quick talk on heart failure diagnosis because heart failure is obviously such a huge topic. We won't cover treatment today, but just focus on diagnosis. So, patients with acute decompensated heart failure can experience terrible shortness of breath and fatigue, which really makes their quality of life a challenge. Beyond this, though, if their heart failure goes untreated, they can develop cardiogenic shock, renal failure, liver failure, and even die from this. So, as clinicians, we can give patients a fighting chance by identifying heart failure early and starting treatment. So, let's talk about how to diagnose heart failure. I think the first thing to consider is what is heart failure at a physiologic level. From my perspective, heart failure is when the heart is unable to allow blood flow through the heart to the lungs as well as the body. And I will write little shorthands. Okay. So, if your patient comes in to the ED, what would make you concerned about heart failure as being a reason to admit them? Well, if they're telling me about some of the symptoms I mentioned, such as fatigue and shortness of breath, those are really major ones that make me worried about heart failure. There might be other symptoms that they mention as well, including edema, like lower extremity edema. They also might talk about abdominal pain generally, or right upper quadrant pain, and orthopnea is common. Okay. And of note, dyspnea would be secondary to fluid overload, while fatigue is secondary to hypoperfusion. Okay. And then on exam, what are some of the things that we're looking for? Well, things I like to look for, I break into two categories. The first being a volume exam. And then I also look at like a cardiac exam. So from head to toe, the volume exam I'm thinking about would be fluid along around the lungs, which could manifest as a pleural effusion. It can manifest as rales on exam. And then it can have lower extremity edema as well as JVD. On their cardiac exam, you might notice an S3, which is pathognomonic for some type of left ventricular dysfunction. You might notice some pulsus alternans. And the other ones I wanted to talk about were increased heart rate. And you could also have a displaced PMI because of left ventricular enlargement. All right. And then after you've done an exam, typically we go to labs, but in this case, if there's a suspicion for heart failure, we actually go right to imaging first. So there are three imaging studies that we typically get, and those would be chest x-ray, EKG, and echo. Here we're specifically talking about a TTE. The chest x-ray is going to tell us a little bit about whether they're fluid overloaded, but it also could tell us if there's a different reason that explains their dyspnea and the fatigue. So chest x-ray, we can look for fluid, E lines, that kind of thing. And then EKG, we can talk a little bit more about when we look at reduced ejection fraction versus preserved, but it can also help us identify MI as an underlying cause for their heart failure. Echo is also an important distinguisher. What is the specific metric we're paying attention to on an echo? Well, the most important one for us here is left ventricular ejection fraction, and that's key. All right. So once you have this much, you would be able to tell whether the patient has heart failure or not by plugging things into the Framingham heart failure criteria. There's no point in really memorizing it, but there are minor and major criteria that the Framingham heart failure calculator uses, and you can just find this on MD Calc. Going beyond this, though, we have to determine whether the heart failure is reduced ejection fraction or preserved ejection fraction, because this can change how we manage the patient. So starting with reduced ejection fraction, this is the most common category of heart failure for our patients. It is due to systolic or diastolic dysfunction. This one is due to systolic dysfunction. It's a left ventricular problem, and just generally a left-sided problem. If the left ventricular ejection fraction from our echo is showing, let me write it in red instead, less than what? Does it need to be categorized as reduced ejection fraction? That would be 40%. And that would equal breath. Okay. Also, looking at the EKG, so this would be 4. And then if we look at the EKG, what would it show? Well, typically it'll be a normal the EKG we'd look at, and if it's normal, it's most likely not heart failure with a reduced ejection fraction. In other words, a normal EKG has a 99% negative predictive value for ruling out heart failure with reduced ejection fraction. You'll typically expect there to be signs of left ventricular enlargement on this EKG. After we have identified the patient has HFrEF, then we want to go on and get some labs. There's 4 labs to get, and it'll help us rule out and rule in heart failure, as well as get a sense of underlying cause. So in terms of the labs, the ones we want to get are BNP or proBNP, CBC, CMP, as well as TROPS, typically high sensitivity TROPS. BNP we get in order to rule in and rule out heart failure. So if the BNP is less than 100, we're able to think heart failure with reduced ejection fraction is pretty unlikely. Whereas if it's greater than 400, let me write it in red, greater than 400, then HFrEF is more likely. When you're in between here, 100 to 400, it's kind of like equivocal. You have to pay attention to the other signs and symptoms. For CBC, we're specifically looking at whether they have anemia, because this can trigger heart failure in patients with underlying heart failure. And then a CMP, we're looking at LFTs to assess for any liver damage, which makes heart failure more likely. We're also going to be looking at creatinine for signs of kidney damage, and lastly, hyponatremia, another sign of more severe heart failure. Lastly, high sensitivity tropes helps us rule out MI as an underlying cause for their heart failure. All right, so that's reduced ejection fraction. To recap, if the echo ultimately shows a left ventricular ejection fraction of less than 40%, we call this HFrEF, or heart failure with reduced ejection fraction. Okay, so talking now about HFpEF, the difference here and why we go down the left side of this chart is if this echo shows an LVEF, left ventricular ejection fraction of greater than 50%, then we only know that it's possible the patient has HEF. They could have other causes, they could be totally normal, and so this only tells us it's possible HFpEF. So that's why we have to go down to the next step and decide, do they have other reasons to increase their HFpEF chances, looking at other variables. Big ones here is if they have dyspnea, and if they have AFib on their EKG, then there's a 20 times increased chance that this is HFpEF. But even this doesn't make us certain that there's HFpEF, so we'll use a second calculator, the H2FPEF score on MD-Calc as well, to help us determine whether this patient's likely to have HFpEF. If their score is greater than 6, then we just say that they probably have HFpEF and stop the workup from there. The things get tricky when it's less than or equal to 6. Then we have to go on and get another test. Here again, it's the BNP. It's your 5th test. And the BNP of less than 150 is also equivocal, but a BNP greater than 150 makes us land at the probable HFpEF camp again. The other test to do would be a right heart cath or a Swan-Ganz cath. And this is an invasive test, which is why we try to avoid it if possible and get away with these less invasive ways of diagnosing the patients. But if things are equivocal, you might have to end up doing a right heart cath. And on this, we're looking at the pulmonary capillary wedge pressure. So the way to diagnose definitively that the patient has HFpEF is to have a pulmonary capillary wedge pressure of greater than 15 at rest or greater than 25 with exercise. Okay. There's one other criteria that considers cardiac output, but we will keep it simple today. If the pulmonary capillary wedge pressure is less than 25 with exercise, then this also definitively rules out HFpEF. All right, so here's the completed diagram. Thanks for listening.
Your time is precious, so thanks again for joining me for this talk. Until next time.